Good morning. I'm gonna be speaking in Spanish and, well, good morning, everyone. We're gonna begin. And I hope that you are able to listen in the right language. Now we'll go with Dr. Andrea Vicare, and he is from the Department of Health Emergencies from PAHO. Good morning, Paula, and good morning, everyone. I apologize. Right now, I have some problems with my camera and I can't be on video. I apologize. You can't see me. And but I'm here. I wanted to thank all of you for connecting. I wanted to welcome you to this morning seminar that I think is extremely interesting. And we are introducing the PISA tool. Uh, this is the assessment for respiratory viruses. I'd also like to thank the speakers for their participation. Dr. Aspen, I'd also like to thank Geneva and the WHO and Dr. Paula Rodriguez Ferrari, the coordinator of respiratory viruses for the Ministry of Health of Chile. In the seminar, we're trying to enhance the use of evaluations and its importance at a global and regional level. I think this is something extremely important, and I think this is an elegant approach because it brings together not just the transmission but also criticality and the end impact, the impact that the different uh, pandemics can have at a seasonal level. So it's a very useful tool, and it provides a perspective for surveillance data that is very important. In PAHO, we specifically produce PISA indicators per country through the through the FluNet platform, and this should improve the representation. We will also be presenting a dashboard that is being developed, and we hope will show the relevance of this tool as well. So I believe that this will be something that is going to be very useful and I hope inspiring in terms of advancing on this. So I would like to again thank all of you for joining the seminar. And of course, I thank the speakers for their contributions. And I again apologize uh, for because you can't see me because I'm having problems with my camera. Thank you very much. And I hope we have a successful webinar. Thank you very much, Andrea. Thank you very much for your welcoming words. And so that we can avoid any further delays, we are going to give the floor to from the WHO. We're gonna hear the presentation on the advances of PISA and the perspectives of the WHO. Um,
I didn't. One sec. One second. Is that all right? Yeah. Hope you can see the right slide, the right screen. Okay. Thank you. So thank you to Andrea and Paula and all PAHO colleagues, and thank you for joining. I'm Aspen Hammond from the WHO Headquarters Global Influenza Program, and with my colleague Cedric Battiano, we will give a brief introduction and background on the Pandemic Influenza Severity Assessment guidance that was updated over the past few years and was published last year. So again, the updated PISA guidance was published in 2024. The first guidance was published in 2017, addressing a need to assess severity of influenza pandemics that was identified following the influenza pandemic in 2009. The tool is intended to be a flexible tool, as Andrea said, to be used by countries to be able to better interpret and communicate their routine respiratory surveillance data. It can be used to make assessments each week of influenza severity and also the end of season assessments during seasonal influenza epidemics, but also in any future influenza pandemics. And the reporting of weekly assessments from countries to WHO through the regional platforms helps WHO to better understand the local and global influenza activity and severity, and helps us to inform guidance, situation reports, but also helps us to enhance our overall influenza preparedness. The objectives of PISA are to summarize current influenza activity in the context of how the current activity compares to what has been seen previously in previous seasonal epidemics and maybe in past influenza pandemics. So this is the critical part of PISA is that, again, it's using historical surveillance data to calculate thresholds of activity and to compare the current activity to these thresholds. So again, putting the current influenza activity in the context of what has been seen previously. And we can visualize this by having these nice colorful charts that indicate the threshold levels and the intensity levels, and putting again the current influenza data on top of those thresholds. So for example, you can see here on the right, different colors indicating different levels of intensity. Below the seasonal threshold or the epidemic threshold, a low level of activity in yellow, moderate in orange, or high in red, and extraordinary levels in the purple, with the black line indicating the current information. So we can say right now, at this week, we are seeing moderate activity in relationship to what we've seen before. So again, the objective is to interpret and contextualize current activity, and this can also help us inform response measures. So which kind of public health and social measures might be appropriate if we're seeing this level of influenza activity. And thresholds, again, allow us to put the information, the current information, in the context of previous activity. So again, we're showing here an example of a country's use of thresholds and putting the current data in the context of those thresholds. So on the left side, you can see just the current, for example, the current week's activity. But if we take that and superimpose that activity on thresholds, we can better communicate the intensity levels. So we can see that for this example, the current week would be activity level is below the threshold, but at the peak of activity, it reached a moderate level, or in this case, a high, which is the orange color in this example. Some important terms that we use in PISA, which are reviewed in more detail in the guidance. We refer to data sources as those kinds of surveillance data coming from specific systems that you might be collecting, whether it's syndromic surveillance or syndromic surveillance with laboratory testing. Maybe you use participatory surveillance, or you're monitoring healthcare resources and capacity. The guidance also gives information on how to use modeling and forecasting sources. And when we refer to parameters, that refers to the specific type of data you're using, whether it's, again, the ILI proportions or ILI rates or SARI rates or proportions or influenza admissions to intensive care. And the other important term that we use is indicators, and this is really to the core of PISA. PISA is based on 4 indicators: transmissibility, seriousness of disease, morbidity and mortality, and the impact on the health system. So, as I said previously, the PISA guidance was updated last year. It was updated to consider some of the key lessons that were learned during the COVID-19 pandemic. We know many surveillance systems were severely disrupted during the COVID-19 pandemic, the routine respiratory systems, but at the same time, new systems came on board, or existing ones were modified to be able to monitor SARS-CoV-2 activity as well. So the guidance was updated to consider some of these changes that happened. The other important change was that there was a desire to have an indicator that would help us monitor the use and capacity of the healthcare resources. So looking at how full the hospitals or the ICU wards might be as a consequence of respiratory activity. So again, this is an additional indicator. This was added in the 2024 guidance. So it's looking at how we can look at systems meeting the demand and being able to provide care for respiratory virus epidemics. And being able to use that to then make changes if you're at the peak of activity and the respiratory wards may be overwhelmed, how can you make changes, using other wards, making changes in staff, et cetera, to be able to lessen the burden on the healthcare system. So in addition to looking at the intensity of influenza illnesses and deaths, PISA is also adapted to be able to look at the impact on the healthcare system. And this was really important, again, coming out of the COVID-19 pandemic. Another important change in the PISA guidance when it was updated last year is that now that we have multiple respiratory viruses that are circulating, so we have influenza, we know we have other respiratory viruses before, but now since the COVID-19 pandemic, we have SARS-CoV-2. So the guidance was updated to be able to account for looking at the intensity of respiratory activity in general, so using syndromic parameters, but also looking at the intensity of influenza-specific activity. And some countries have also started looking at their respiratory activity due to SARS-CoV-2 specifically, or RSV specifically. So the guidance had to be updated to now consider influenza specifically, but also considering the continued use of syndromic surveillance. Again, this is because of the co-circulation now of SARS-CoV-2, and that also causing quite a relative burden on healthcare systems and respiratory morbidity or mortality. Many countries continue to use syndromic surveillance, but we also know that it's due to different viruses, so we can understand a bit better the relative burden on the systems due to multiple viruses that are circulating. So countries may have different types of data or parameters that they can use to look at influenza-specific or syndromic severity assessments. And the guidance goes into detail on which parameters and how to use these data to come to these assessments. I will turn the presentation to Cedric to go over a bit more detail on the actual steps in the PISA guidance.
Thanks, Aspen. Can you hear me?
I can.
Good. Thanks. So now that we have a little bit of the background and then rationale For the PISA steps, we have 4 main steps. So the first one would be to be capturing or selecting the parameters from the existing surveillance system that you want to use to inform the different PISA indicators that we just talked about. And we don't need to be collecting new data, which is using the data that is available from our surveillance systems. And in the guidance, we have a table with examples of parameters for each of the indicators, each of the 4 indicators involved in the PISA. And the second step will be using the historical data from the surveillance system to calculate the different thresholds we talked about. And again, in the guidance, we have guidance on how to select the methods, and then how to evaluate the result that we get. So basically the thresholds. And the third step will be to interpret the data to assess the severity. We also have guidance on using the context of your country to upscale or downscale your assessments. And then the last step would be to be reporting and communicating reporting the result of your assessment to WHO, and then also to communicate the result through your national outputs. And for that, for the reporting to WHO, we have new global outputs that we are working on to be displaying all those results. So at the right hand, we have again our graph that we saw before. So what we want when we set threshold in PISA, for example, we want only 2.5% of the peaks. The peaks of the historical data that we use. So basically the time series to be falling into the extraordinary level. We want 10% of the peaks falling at high to the extraordinary level, and 60% of the peaks will be falling between the moderate and extraordinary levels. That way we ensure that our peaks are, and then our peaks are well distributed throughout all the thresholds. Next slide. So these are the 3 indicators that we had before in the 2017 guidance. So we had the first one is the transmissibility, which describes how many people in our population get sick from influenza. And using that indicator, we are able to assess the level of community transmission through the presentation with mild illness. And some of the parameters that we can use to inform that indicator would be, for example, the lab confirmed influenza cases or the consultation for ILI. And like I said, we have more parameters that can be filled for that indicator that we have in the guidance. The second one is the seriousness of disease. That one look at how severely sick individual get when infected with the virus, and we use that indicator to assess the seriousness of disease in people infected through we're using proportions here or ratios of serious illness relative to less severe illness. So basically, one indicator, for example, that can be used to inform that indicator will be the number of deaths divided by the hospitalization for influenza, or the ICU admission divided by the number of hospital admission for influenza. And the last one for the 2017 guidance is the impact, which looks at how the influenza epidemic affects the healthcare system and society in general. And this indicator is there to assess healthcare system demand and the impact of the epidemic or the pandemic on the healthcare system. Next slide. So with the revision in the last guidance, we split up the last indicator, the impact, into two different indicators. So we now have the morbidity and mortality indicator, and then we also have the impact on healthcare capacity indicator. And my colleague Aspen gave you the rationale behind that separation slide earlier. Next slide. So to be able to use your data on PISA, we do have some minimum requirements. So PISA uses data from existing surveillance system. Like I said, you do not need to be collecting additional data. And the minimum numbers of surveillance parameters that you can use to do PISA basically is one. So you can use either ILI or SARI. But if you have more parameters in your surveillance system, it's good to use them because it will give you, view on different aspects of your activity. And the minimum length of historical data that you need is 3 years. It's recommended to be using 3 years to be able to effectively use the different threshold setting methods. Next slide. So these are some examples of countries that are already using PISA in their national report. So this one is from South Africa. So we have two indicators here. So we have a transmissibility. So they use two parameters to inform that indicator. So the first one is the person positivity for ILI, for influenza from ILI surveillance in primary health care. And then the second one is the person positivity for influenza from ILI surveillance at the GPs. And for the morbidity and mortality indicator, they use the person positivity for influenza for pneumonia surveillance. And then they publish this national report each week. Next slide. And these are some more example of countries using PISA in their national report. So we have 4 examples here. So like Aspen said, PISA it's really a flexible tool that countries can use to report on influenza and respiratory viruses activity. And like you see in the graphs on the slide, you can use the approach the way you want to use it. And you can also, style using the colors or the style that you want to be putting in your national report. Okay. Yeah, and for the reporting step to WHO, WHO doesn't collect, the raw data that you use to do PISA. We only collect the weekly indicator scores and the contextual information linked to that indicator score. And we then use this data to assess the global influenza severity and provide better information and resources to member states. And other countries can benefit from those global outputs. And for example, looking at the trends in their own country, but also in the neighboring countries. And you have an example of 2 visuals that we have on the application where we display the result. For example, we have how on the graph on the left shows how the situation evolves throughout the year for each of the countries. So each line here is one country, and then you see how the threshold scores kind of evolve throughout the year. And we also have the map at the right-hand side where we can see also those levels at the global level. Next slide. Yeah, Aspen, you want to take it back?
Sure, thanks, Cedric. I'm just going to conclude with a few slides on reporting to WHO because this has been updated to be aligned with the updated guidance. So now there's an option, as I said, to do severity assessments on syndromic data, like ILI or SARI, but also on influenza-specific parameters. And so the reporting template and RespiMart has been updated to be able to accommodate those changes. The other change in reporting is that, as we said, the guidance indicates that the reports from countries are to be published on the WHO website. This has not been done yet, as we're still fine-tuning the outputs. But because of that, there is an additional step that needs to be done one time before uploading data, and that's to agree to the data sharing, so that you're agreeing that what you report there can be made public. So again, that's done one time, and once that's completed, that allows the reporting information to RespiMart to be able to be done every week as you make your assessments every week. And again, this may be different depending on region and country. Some countries report data directly to the WHO global platform RespiMart, whereas some countries in other regions report to their regional platforms as well, or instead. And again, once these are, the information is shared to RespiMart, once we are finished with the public outputs, then we would put those on the WHO website and the Global Influenza Program page, providing some contextual information to say how these agreements or these severity assessments were made in the countries. But also importantly, we know that sometimes the assessments are revised in further weeks, so there may be updated reports that are published as well. So again, just to summarize the guidance, the PISA guidance, I think many of you were familiar with it and had been trained and were familiarized with the guidance from several years ago. The guidance was updated last year. There's an additional indicator. Essentially, the impact indicator was divided to two, so morbidity and mortality and impact on healthcare. This updated guidance allows for severity assessments on syndromic surveillance data, as well as influenza-specific information. Again, it includes a measure on the impact on healthcare capacity. So this helps us understand how well the systems are managing the burden and demand of respiratory infections. PISA approach still, as it always has, can help countries with the interpretation and the communication of your routine surveillance data. And it helps WHO improve our understanding of the global influenza activity, the severity, and allows us to communicate if there are any short-term responses that need to be made. And it also helps us prepare for future pandemics, because PISA is the title includes pandemic influenza, but the important message for PISA is that it's meant to be applied even during seasonal epidemics, so that we're all better prepared to apply it if there is a future influenza pandemic. So that concludes the presentation from us. So thanks very much, and we're happy to be here and to answer questions when the time comes. Thanks.
Thank you so much, Aspen and Cedric. If that's okay for everyone, I was writing in the chat to please share the questions for each of the presentations so that we can address them at the end all together. So I'm going to switch to Spanish. Y ahora lo que vamos a presentar es desde...
Now, what we're going to present is, well,
Wait.
So now what we're going to present comes from the regional team.
Well, thank you to Ethan and Cedric for having allowed us to take a look at the framework of the evaluation of the pandemic influenza severity, PISA. And the name of this tool is, has been mentioned, or this indicator refers to influenza, but through our Chilean colleague experiences, and later on, we're going to see that it's actually being used and is extensively applied to other respiratory viruses with validation procedures also that are at stake. So we have this brief presentation by myself and my colleague Luis Fernando Quesada, who's also developing all the dashboards of the team. We wanted to make this proposal an update of how pandemic influenza severity assessment is being used in the region. As Dr. Vigati said, since PISA started to be implemented globally and in the region, we have tried to improve it and use it more and more in the region. And this synthesis shows this intention, and also the idea is to share with you info exchange and connection to these indicators, and how we propose it to be used without necessarily changing it, just ensuring there's the bigger representativeness in the region and the information is more available. As I mentioned, I just wanted to remind you that among the activities carried out by the team, we are interested, and it's part of the cooperation to carry out training, distribution of materials, adaptation of online tools, which are the methodologies to generate intensity levels and the parameters that were presented before, and also make sure that these capacities and the use of this tool is extended all along the region and not only in just a few countries, because we realize that it's very useful. This information should be used as part of risk evaluations that can feed more comprehensive risk evaluations, and that they can be used during seasonal epidemics. And that's also part of our activities and cooperation. Most of this time in which we have been implementing training and testing PISA for influenza and also other syndromes, out of the indicators our colleagues mentioned, the most frequent are those that show communicability or impact, and in lesser countries, in fewer countries, they use severity indicators, at least up to this date. And one of the challenges and why we make this presentation, it's because we want to make PISA more representative and generate a regional perspective, risk evaluation, and evaluation of the severity at sub-regional and regional levels. These two slides are simply an illustration to show how PISA data are exchanged. and managed at every level. And the following slide shows our proposal for having more countries and teams to join in the use of PISA for their report and for their own benefit. So to date, based upon what Aspen and Citric said, each one of the national teams use surveillance data, both epidemiological and virological, to generate these templates and report PISA indicators, which are recorded in a specific template because they require evaluating the quality of indicators. It's actually a qualitative analysis. There are countries that directly reported to WHO, and other countries reported through the regional team, as well as the other information they send, which is immediately shared to be used and feed the global platforms. This allows to understand what the severity status is concerning seasonal epidemics, and also, as it happened in COVID, of respiratory pandemic, at least at the beginning. This is the flow to the moment, to this moment. And the proposal we want to present to you and listen to your ideas during the debate too, is that we try to have these indicators have more representativeness, particularly concerning impact. You also produce severity analyses concerning influenza in your teams, but we can also inform and make all this available at regional level, and also trying to prevent the burden this can mean. Our proposal is that, well, each country domestically would always continue collecting information through their surveillance strategies and exchanging that info through PRIDE-CluNet. And we can't read very well, excuse me. And also the PISA templates, the country directly reporting, and that would be the same. However, the change we're proposing at regional level is that countries that are not reporting PISA indicators now, but which are interested in having this reflected at all levels and for themselves, we would propose to them that with the variables from countries build, we can build PISA indicators with the other two FluNet and FluID. These indicators then can be transferred to the PISA format, and they can be used as PISA indicators for those countries. Of course, we would have some previous meetings to agree that those intensity levels, indicators, variables, parameters are aligned with what the country considers is the reflection of their current scenario and of evaluating the epidemic in the season. And now I'm going to pass the floor to Luis Fernando. But first, I want to say that we'd like to generate these analyses through this to have severity evaluations at regional level to share with you and feed you back. Globally, this would also allow us to have more detail, and the global level would have a more timely information on respiratory epidemics. This is a proposal. We wanted to take advantage of this webinar to share this with you, and we'd like to listen to your comments. I'm now going to pass the floor to Luis Fernando, who's working on this with lots of dedication. Thank you very much, Paola. Well, these graphs we are sharing with you are some proposals of how we can regionally view these PISA indicators. As you can see on the screen, the first graph shows the percentage of countries we have at every transmission level per sub-region. This allows us to see where is more and less activity in what region or sub-region at a certain period. And on the right, we think we should know what is the number of countries in the current week with that transmission level. Next slide, please. We'd also like to show this information, as Peter mentioned, a long time to see how activity levels vary along the year's epidemiological weeks. We can have a view like this one where we have information for a sub-region and the number of countries that are at each transmission level. The third view would be the possible table that we can generate with this data. We think this is very interesting data. We think that this is very interesting and informative. We can have all the countries here, then we detect the trend, use the last 4 epidemiological weeks as datum, if available, and this is shown in the blue lines, and we identify an upward or downward trend. And the PISA transmission level for the last week. It would be a very interesting table, and we can have it with these data that will show us both the magnitude and the trend direction. Okay, that's it, Paula. Thank you very much, Luis. We're going to have several questions, I think, at the end. Before going to our colleagues' experiences from the Ministry of Health, the Chilean Ministry of Health, I'd like to remind you that the automation of PISA indicator reporting will facilitate timely reporting and improve data representativeness and availability. Sorry. The idea is that it will enable real-time analyses and also assessments and supporting risk evaluations. These dashboards are an ongoing process, and they would allow us a more real-time analysis of available data every week. This would help us to analyze risk and different situations in each country. Our intention, as possible, is to integrate PISA into routine surveillance, because this will strengthen timely detection of changes in trends and severity. A standardized reporting system would also help us to improve comparability between countries and strengthen coordinated regional and global responses through feedback. We must highlight that PISA is a qualitative evaluation. The intention of automating it is to focus on evaluating surveillance quality, data quality, and evaluation quality. I finish with this. Thank you very much. Thank you, Luis. I hope we're not so delayed. I see there are some questions coming up. Do not hesitate in sharing your questions in the chat. Now we're going to have Dr. Paula Rodriguez Ferrari from the Ministry of Health in Chile. She works at the Epidemiology Directorate, and she will make the presentations of her country's experience in using these indicators. Go ahead. Thank you for being with us. Thank you very much for this invitation. I hope you can hear me well. Sometimes I have problems with my sound. Yeah, we can hear well. Very well, thank you. We're going to talk about our country's experience by using the PISA. I'd like to give you some context about what we do and how we do it. First of all, we have to understand that this is a country in the Southern Hemisphere in the Americas. We have a temperate climate, and we have very marked seasons in our respiratory viruses. We have lots of viruses in winter, and this allows us to analyze them too. We think we will reach 20 million inhabitants for 2025, and our influenza surveillance app has 7 components. ETI, Sentinel, SARI, Sentinel, Lab, Sentinel, Outbreak, Universal, Urgency, Care, Universal, so on. But the SARI, surveillance, acute, serious acute respiratory infections. Since 2024, we have 14 SARI hospitals in 3 of the 16 regions in the country. We have been doing this since 2012. We have systematized information and IT platforms since that year. We have the SARI case definition, which is more than 38 degrees fever, cough, and respiratory difficulty. 100% of the SARI notifications that get into the system come in with a respiratory sample analyzed with RT-PCR for the 8 respiratory viruses we have available in our country. With that, we can think about how to adapt PISA indicators, selecting different parameters to this evaluation. First of all, communicability, using influenza and CRS positivity per specific age groups that we constantly monitor. Concerning severity, we use SARI proportion on the total of hospital entries for all causes in Sentinel hospitals. And for impact, we make a difference between SARI that require ICU compared to the total of entries to ICU for all causes. And then we check the groups to be analyzed and the methodology. We use the WHO method with weekly positivity to determine the epidemiological level. For 2024, we used several seasons, long period of analysis. We considered data from 2014 to 2023, not counting 2021, 21, and 22. And for 2025, we have used the 2017 to 2024, not counting 2020, 2021, 2022. What can we do with this concerning communicability? we must remind that communicability has to do with positivity to the virus, as we two age groups, under 5 and over 65. And we have a sentinel surveillance for these two groups concerning carry and how the influenza virus behave in these age groups concerning those who need hospitalization. And we also follow the surveillance of the Chilean Public Health Institute, which is our national influenza center, and check the differences concerning communicability at these ages. We see we don't have many hospitalized people in this age group associated with this virus. However, when we see this as viral check, we have a great increase as compared to history. The same thing happened with over 65. We saw differences that are subtle. For example, in SARS surveillance, we had a season with a very high circulation of influenza, which affected people over 60 a lot, and with an anticipated behavior in both surveillances for hospitalized patients and in the case of lab findings in our Sentinel lab. It was even higher in the surveillance of respiratory viruses done by our National Institute. Now, for VRS, the situation was very peculiar in 2024 for the first time. We incorporated the monoclonal antibody against VRS in specific groups that are considered as serious cases for us. In that case, we gave the monoclonal antibody to newborns that were born from October 1st, 2023 to April 2024. And after that period, we checked the country. This was a strategy with a national approach. You can see in the SARS surveillance concerning people who require hospitalization for VRS under 1 year, we expected to have a season that would be marked on week 26, but in 2024, we didn't have that viral circulation. We did have VRS circulation, but these people didn't need hospitalization thanks to the monoclonal antibody. For those older than 65 in VRS, we had an increase in the season that was quite similar to what we expected, but we also saw the differences between the surveillance of hospitalized people and people who got sick or got infected with this virus, and in connection with the lab finding we had. Concerning severity, we do not consider the proportion of people who require hospitalization based upon the total hospital entries for all causes. And there you can also see an atypical season where we saw a decrease of cases in the middle of the year, which is not very, which is very seldom. And this is the shape of the season. So the tool was showing us we were having a season between the median and moderate thresholds in the year. For impact evaluation, as I said before, we used the entry to ICU, serious SARI or severe SARI requiring ICU on the total of ICU entries for all causes. Again, it was a season that was not very typical with 2 peaks and we expected to see actually a considerable increase of cases. We didn't use these indicators once or twice a year, but every week of the year during the winter campaign. We have this winter campaign, which is the strategy in the country that contemplates planning, programming, executing activities to respond to an increase of respiratory diseases, aiming at decreasing morbid mortality due to respiratory causes, particularly in risk groups. And we use these indicators to this. We have a weekly meeting, national meeting, where we show the situation or the status of respiratory viruses, and we use the PISA indicators to show what's happening in the season along the weeks and how the viral trend changes as compared to our historical data. We do that for influenza and for VRS, as you were able to observe. VRS is the SRV in English, sorry, the syncytial respiratory virus, to prioritize resources or actions, and then to have epidemiological alerts based upon the observed activity. Of course, we have to continue exploring this methodology in other areas. For example, one of the components that we have not implemented yet, but we want to do is to use it for fatalities due to respiratory diseases. What have we learned from this methodology? We have learned that it is adequate to measure the respiratory virus activity level. It allows us to quickly understand the epidemiological current situation due to respiratory causes. We have used it for decision making, for managing the health network in our country. And we have adapted these indicators more and more to see how we can continue using them for this management. As I said before, in 2025, we decreased the number of analyzed seasons because we were able to better diagnose this after the pandemic. So we use more current data, which simplifies our work in this new post-pandemic reality. And we also see that age groups have changed. We use influenza and severity for children under 2, from 2 to 4, and older than 60, and we use it as pediatric and adult, so the health network can move their resources for pediatric and adult patients in terms of beds. We use it not only to check the activity, but also the actions that we can take to adapt to the situations. Thank you very much. Thank you very much, Paula. On behalf of the Chilean team, it's always a pleasure to listen from your experiences. Let's continue until the rest of the presentations and take the next phase to be used for questions about the presentations. There are more than 100 participants and the colleagues in the from the colleagues in the network. They'd like to share perhaps their experiences also in comment if it's similar to Chile, or if they use other approaches or other respiratory viruses. So thank you very much for this.
If you have questions, you can share them in the Q&A tab. You can raise your hand or you can write them down in the chat and we will answer. In the meantime, I would like to ask first Paula, and then the question is also open to Aspen and the colleagues from WHO. Related to this last point about the number of years or the seasons that you use for the analyses, I understand that do you use a specific number of seasons starting now that is standardized? And how many did you use before? And is that number of years that you use, is that also applied when you explore influenza indicators and also the RSV? And well, as I was saying, in 2024, we used a long period of time to understand how to see how the impacts came out of the tool. And then we decided to reduce the number of years because what we see in the statistics since 2014 to 2023 doesn't really change, but the change is in the number of sentinels that we have, the diagnostic capabilities of these sentinels, and we have the strength that our surveillance of influenza and other respiratory viruses has data about respiratory virus since the beginning. So we have information about that since 2012 for RSV. But since the pandemic, we have more sentinels that have molecular biology diagnostics, which brings us more data for respiratory viruses. So we are using a smaller number of years. We're using 5 years in the methodology and excluding pandemic years. In our case, we took out 2020, 21, and 22. Thank you, Paula.
Thanks. It's a good question, and maybe I let Cedric. Cedric is quite experienced with threshold setting. He can probably give a bit more detail, but I think as Paula said, it probably requires some experimenting and looking at what changes when you include more or less historical data. Maybe at a certain point, using more doesn't change anything. So I know there are some countries who use maximum 5, and every year they update, removing the oldest and using the new one. But Cedric, maybe you have other experience as well.
Yes. So the recommended number of seasons to be included is 3 years, because it's like a optimal balance to render, I would say, meaningful threshold scores. But really, both methods, I mean, the average curve method from WHO and the MEM method, recommend to be using, if you have 5 seasons, it's good to use them. When it comes to the, how much you can have, let's say you have 20 years, 20 seasons, do you want to include all 20 seasons? So we had a lot of discussion around that, and then there's a quite interesting study that have been done by one of the modeling working group at WHO. His name is Johannes. He's from Germany. I did an interesting study showing that when you use between 5 and 10, you usually get good result. but using more than 10 actually hinders the result. So the optimal, I would say, window of season to be using is between 5 and 10. I will send you the link for that simulation work. It's actually a published paper showing that, the balance between, less year or more years. So like Aspen said, one of the good practice that people use out there is to use 5 years, and then each year when they have the latest season, they would drop the oldest season in the set and then add the new one so that they consistently have 5 years going forward. There's also an interest of dropping the pandemic years data when setting threshold, because for most countries, the time series in that period are kind of disrupted. We don't have this typical up and down in the time series, and then that can influence the threshold scores, because you know that we use the values in the peaks. The values of the peaks are used to set the threshold. So if you have a lot of inconsistencies in the peaks that you have in the period, that can actually drag down or up your threshold. So you might want to check your surveillance system, looking if the time series that you have in the pandemic period are kind of, good, if they're really actually showing the reality of influenza that season, you can use that. If you see that you have a lot of disruption, it's better to drop those years. So yes, I will send the link of the paper now in the chat.
Yes, that would be very useful, because it's a ongoing question, and even more so with trying to assess for SARS-CoV-2 in the future. So thank you so much, Cedric. I would go ahead and go through some of the questions about the reporting countries to PISA. I was referring to the countries that as Chile, using the methodology and also sharing through templates, either directly to WHO or through flu@paho.org as FluID and FluNet. It wasn't meant to, and it's not to put everyone on the spot, but it's more about sharing the challenge that we have in terms of trying to gather or to be more efficient or in using the data that's already available and shared, because you share through FluID and FluNet data that is, like Cedric said, of good quality and already review, to use that to combine for parameters that may eventually feed PISA indicators. It's not necessarily to go through that path, but it's more for us to have an understanding of a regional and global assessment. And if in the end that proposal end up for all of the national teams, and you here agreeing to say, oh, actually, this is something that represents what we are seeing now, and this represents the indicator that we are assessing, and we are okay with you using that instead of us sharing. Okay, but it's not written in stone. It's more about discussing with you. I hope, Jean-Denis, I was able to reply that question. And the question that I have another question from Brazil, Fernando Mota from the Fiocruz, Nick Fiocruz. He was asking if the PISA analysis have in consideration vaccination campaigns, and how would the analysis be affected in the case of vaccination, for instance, for flu that's available all year round. I would leave it to both Paula and Aspen to share the inputs. Thanks.
Maybe I'll start. I saw the question. Hi, Fernando. It's nice to hear from you. The PISA methods themselves don't consider vaccination. it's using the routine surveillance data in the context of the country's own historical surveillance data. So, you know, so if there's a vaccination campaign that's ongoing and has been ongoing, I guess I'm not sure that it would necessarily be considered in the PISA methods. It doesn't currently consider vaccination, only it's using routine surveillance data. Maybe it could help you understand maybe timing of vaccine campaigns, groups maybe to target. So I guess that would be my input on that question, but I apologize if I didn't understand the question so well, but maybe other colleagues can provide more.
I'm sorry, I will answer in Spanish, and that is so that I I don't force you to try to understand my English. Okay, in our case, we don't include it in our analysis, PISA analysis. We don't include the vaccination campaigns and their advances, but we do have a more qualitative evaluation. As you saw, the previous season, we had two peaks that were specifically associated to influenza. And when we look at the vaccination campaign and the coverage, we can see that the month that we saw the greatest increase of influenza, we also had a big media event in our country. This meant that many people went to get the vaccine. We had very high rates of vaccination coverage in a few weeks, and that influenced that very fast drop in influenza infections. But it's not the only way we look at it. As I said, we also have these national meetings. We call them winter campaign. And at a national level, and it's not just in the central level in the Ministry of Health, but we also have an instance where we have the Ministry of Health and the health services in all the regions in our country, and we show this information. And we don't just show the information for epidemiology, we also show the information of the vaccination campaigns and where we're giving vaccines, how many vaccines are applied, and the increase of their coverage. We show the beds that are available, the transfers. We show the indicators of a strategy that we have that is called Salud Responde, where any person at a national level can call a Ministry of Health hotline to receive information about, well, to get their questions answered. For example, where they could get a vaccine in the country, or a question about what to do when a person is facing some sort of a respiratory problem. This is an available hotline, and we all work in collaboration to be able to address for example, urgencies in outpatient responses related to respiratory viruses. So we see the advances there, and we do a qualitative analysis there.
Yes, to be adding on that, even though PISA doesn't take vaccination into consideration, when computing the threshold, like we said, if you have parameters in your surveillance system that you can use, for example, age groups data, you can run a separate PISA assessment on the different age groups, and then through that you can have an additional information to see which age groups are actually being, more sick than others. And then direct your vaccination or your other public health and social measures interventions on those. So even though it's not directly linked, you can use PISA as a contextual information to help you scale up or scale down your public health and social measures interventions. Thanks.
Also, Fernando, what Cedric mentions is precisely what we see as more valuable in PISA. It's a challenge to try to link different public health and social measures to what's happening. It's difficult because we need to see the results and we need knowledge, as Paula and our colleagues have shown. We need to know what is the intensity at a certain point, and also we need to link the intensity level with the transmissibility, impact, or severity indicators and what it means in terms of scaling up measures. And in that regard, also include campaigns that can be immunization, for example. So there is some sort of an indirect link, but PISA evaluations can be a tool to inform the following measures to be scaled up during epidemics. Okay, Javier, you have the floor. Thank you. Thank you for the presentations. Thank you, Chile, for your presentation. My question is very much related to what you were saying about the fact that the indicators have a contact with community. So I'd like to know, Paula, about communicating risk. Do you have some example, or perhaps other countries have examples about this? As Paula Rodriguez mentioned also, this is useful for the authorities to make decisions and scale up measures, but also how do we communicate risk to the community?
No problem. I can give some points and Paula, you can add on, but I think it's a really good question. I think one of the values of this is for communicating, maybe not risk, but severity of influenza and maybe other viruses as well, if it's used for that. We see several examples of using it to communicate in some different ways. There are some countries who include it in their national weekly influenza bulletins. Some countries put it on their websites to say this week influenza activity is high, or it remains low. I think linked to the vaccination question, it can be if it's a country that has in a temperate area that has a season, you could say maybe the season has started early and it's not too late to get your vaccine. Or maybe a few weeks later, activity is increasing and maybe it's reached moderate or high levels. And you can also say it's still not too late to get a vaccine. If you're looking at severity assessments by age group, you could use that as a message. We're seeing that current influenza activity is high in our elderly group, who we know is at risk. Be careful when you're in contact with your elderly relatives or friends. Take extra precautions, wear a mask, wash your hands, maybe stay at home if you're sick, or maybe activity is very high in kids. You could say, make sure that if your child gets sick, make sure you go to the doctor, or, vaccines are available, etc. So I think it can be linked to different communications in that way. If you're looking at if you want to communicate, maybe not to the community, but maybe to decision makers, if you're able to monitor the impact on the healthcare, you may say, right now the impact on the healthcare is quite high, and we haven't even reached the peak of activity. So maybe people who are working in hospitals need to make some plans for dealing with a very severe season. Maybe they need to make sure that there are extra beds or staff available. So I think that maybe if I summarize, depending on what data sources you have and what you can use to assess severity can then affect what kind of messages you can communicate. If you can do it by age group and using different kinds of data, you can create different messages to different audiences. That would be my long, short answer. But I'm happy for more experience.
Yeah, no, but it's also as a reminder, there's still and for the colleagues that are connected, there's still the online training for PISA that has one of that presentations that go deep dive into how to communicate and how to use PISA indicators in terms of communicating to the community and so on. So that's a useful thing. And I would add something that you always add, Aspen, is in terms of highlighting the uncertainty of what we are communicating, and I think that's also that strengthens the link with the community and the understanding that what we are communicating it's true, and the confidence, okay, in the teams. So yeah, that's one thing. And there's, I think we're already on time, but there's one last question on maybe this goes for all of us, on how can PISA assessment be implemented considering resources or infrastructure limitations, even lack of personnel. That goes from Madhu, from a colleague from Suriname. I don't know who wants to start. Maybe that will be the last one.
Mm-hmm. I can start and others can add, but I think it's a good question. And I think that with the presentation, it looks complicated and it looks like a lot of work. And I would say that when you're first starting to use the methods and apply it, it does take some time to understand it initially. But the way that it's set up is to be able to set up calculate thresholds that you can then use every week, and that weekly updating, looking at your data and comparing it to your thresholds shouldn't take a lot of time. So I think most of the effort is at the beginning when you're starting. Once you have that in place, you know what data you have, you know what your thresholds are. Looking at it every week should be fairly routine as you look at your surveillance data. The resources, we've tried to make resources available to ease that process. So obviously we have the guidance, but we've also made available or there are available applications that you can upload your data to calculate thresholds. And if you're experienced at using coding, then you can take the code for those and you can adapt it and use it yourself and run it fairly quickly. So we've tried to make some tools available with guidance on how to use them to make the threshold calculation a bit easier for countries.
Thank you so much, Aspen, about that. And I think this is a key question also, because I think it's one of the arguments or the rationale for us with Luis Fer and the team thinking on how we can provide more with what it's already there, provide some automatization or easily available analysis that countries can have, considering these limitations, because we understand that there are limitations, and that's a fact. And it's not about the number of countries reporting, it's about the number of countries. All the countries have the information through FluID and FluNet, and all the countries, most countries in the region have strong surveillance systems. And we feel that we can maybe collaborate in bridging that easy access to putting together or constructing indicators or parameters, sorry, based on what's already there. And that goes for our colleague from Suriname. You already have data in your surveillance system. You already have EPI and lab data. And the question is how we can put those together so that we can provide those indicators. If the proposal that we are sharing with Luisfer and through PAHO, it's something that can help you while the resources gets better or the planning gets strengthened, then that's good. I hope that can work for you. But that's overall the rationale of our presentation, Dr. Madhu, and I hope it can help. Okay, I see. I have one last question, and that's it. About South Africa, actually, but mostly it's about for transmissibility, and it goes for Aspen and Cedric. If you have like South Africa, two indicators, no, the person positivity that comes from the virological component and the ally cases that comes from the component from the epi side, and both have a threshold, so you inform with those parameters the transmissibility indicator. Well, does South Africa use a weighted assessment, or how do they decide which one, if the threshold, if one is in baseline and the other one, like if those are different intensity levels, which one is informed as a compose for the transmissibility? Is it the higher intensity level, or is there a proposal for something more for a decision making? I don't know.
Yeah, I don't, for South Africa specifically, they are currently reporting on transmissibility, I believe, and it's only for the percent positivity for flu in ILI. But looking forward to the updated reporting template, it would be possible if you had ILI to report on transmissibility in the syndromic sense for ILI and transmissibility for influenza specifically. So those two could be reported separately. But going back to the question, if you have more than one parameter that could be used for transmissibility, for example, the guidance, I believe, does discuss how you might consider changing your assessment when you have two parameters to look at. It goes back to looking at how much confidence you have in that representing what's going on, the quality of the data, etc. So I think that it's possible if you were to communicate this in your bulletin or elsewhere, you could include several different ones. But in terms of reporting to WHO, either at the headquarters or the regional level, yeah, you would have to take multiple parameters and come up with one estimate using your experience and knowledge of the systems. So we haven't used a weighting system, no.
Thanks. No, we haven't either, and yeah, it's always good to understand how other countries are doing their assessments. So thank you so much. I think we came to the end. I hope we didn't get you for too long, and that all these sharing of experiences from Aspen, Cedric, Paula, on behalf of the Chile team was useful for all of you. And as I share with Dr. Gerard Joseph from Haiti, we're happy to continue this and share whatever tools, of course, the materials from the webinar right after we finish, so that you can make most of the use of these available tools for your analysis. So thank you again, Aspen, Cedric, Paula. Muchas gracias, Luisfer, también por compartir con nosotros. And well, Have a wonderful day and a wonderful weekend. Thank you for being with us.
Thank you.
Bye,
Bye-bye.
everyone.
Que estén muy bien. Hasta luego.
Adios.
Take care. Bye-bye.